Hi, good evening, everyone. Welcome to the 23rd API DICE program, joint collaboration between API and Abot. Today, we are going to talk about the most important aspect in our life, which most of us lack. We have name, we have fame, we have money, but we do not have enough sleep. I'm sure all of you will agree with me. And today, we're going to talk about this important aspect in our life, good night's sleep and the physical or the mental well-being. And to discuss, we have an eminent panel today. And I am Dr. L. Srinivas Murthy, physician and diabetologist from Bangalore, who will be anchoring today's session. So this is the 23rd API DICE, as I told you earlier. And last Saturday, we have reached a landmark of 50,000 physicians across India we have touched upon through this program. And in fact, the last alone program on last Saturday, we reached 11K thousand. That is 11,000 physicians across India through the virtual platform. And that is what the best part of the virtual platform. We have been transferred from the face-to-face because of the COVID to this virtual platform over the years. And today I'll call upon our president, Dr. Arul Raj sir, to please come onto the dais. And Dr. Shashank Joshi sir to come onto the dais, please. And today's chief guest, Dr. Ajay Khera, to be please present on the dais, followed by Mr. Rajshekhar Akkaraju, the head of quality from Abot. Thank you, sir. Thank you for all your presence. And now let's move on. We know the API DICE was started way back in 2013 by Dr. Muruganathan. It was a face-to-face interaction across India to help the physicians to know about the common topics, the common questions and answers they could get through this media. And today we have transferred, because of COVID, as I said earlier, from a face-to-face meeting to the virtual platform. And we have a small video clipping on this, how we have transferred. I would request the console to just play the video, please.
My dear brothers and sisters, first time with the help of Abbott Healthcare, we have started this live CME in 33 cities, which will cover at least 3,000 physicians and 13 hours of learning.
On behalf of the Association of Physicians of India, I take this opportunity for coming here to listen, learn and adapt.
Welcome you all to the API DICE program. This year, we plan to spread the program to about 50 cities and reach out to more than 6,000 physicians.
Esteemed API member and my colleague, I have a proud privilege to welcome you all to API DICE, a scientific platform in 2017. It is my proud privilege to announce that API DICE has reached over 11,000 physicians in 50 major cities in second largest platform after Epicon.
let me welcome you to the API DIAS 4th edition. These programs, we have decided to make this platform as a virtual program.
Thank you very much. I think that was wonderful to see the recap of how it has changed from the face-to-face CMEs to the virtual. And the best part of the video is we could have a Tirupati Darshan also. So thank you very much for the video. I think now we'll move on to our next session. That is, it's my privilege to introduce our chair and president, Dr. S. Arul Raj. And I call upon him to come onto the dais, please. And just to briefly talk about Professor Arul Raj, is a university first rank holder and a gold medal winner in MD. He's got a number of scientific forums in India and abroad he's addressed. He's got many awards in the cardiology and medicine in national and international level. He's presented multiple research papers in national conferences, delivered many prestigious orations throughout the country, and championed non-invasive cardiology and intensive cares, including invasive ventilation in South Tamil Nadu. And he's worked closely with the National Board Examinations and also with our MCI. And he's emeritus editor of Journal of Medical Guide, meant for practicing physicians of India and the family doctors, and meant for the family physicians. So he's been always a visionary, and his main interest is in the primary prevention of many of our diseases, and he's helped a lot of rural people in that way. And I call upon Dr. Arul Raj to deliver his presidential address. Over to you, sir.
Thank you, Dr. Srinivas, for the nice introduction. Warm good evening to all our, faculties and the participants. On behalf of API, I welcome you all for this 23rd, digital API DIAS. API is, all of us know, it always is for science. It supports and grows science, but not simply an evidence-based science with a good admixture of a clinical touch. It always, welcomes and supports, because ultimately, the end point for the knowledge is its application on the patients. That is where API always differs on the science. And in this endeavor only, this API DIAS came to, existence in the year 2013. Thanks to the unstinted support by ABBOT, scientific support, and we could do it from 2013 onwards. It was a physical program, a face-to-face program. In those 3 years, nearly about 30 programs were done. Around 20,000 physicians of our great nation could be reached and updated on their scientific knowledge and skills. Now, thanks to the our COVID, now we were just breaking our head what to do. The ultimate end is the digital platform. That is what we have, a digital API DIAS. This digital API DIAS has linked all of us. Today, I am in some part of the country and traveling in my vehicle. I am able to participate, I am able to listen, I am able to speak, and I am able to learn. This is an advantage of a digital platform. All of us are here. Now we just listened to Dr. Usha, who is there in, US, morning 7 o'clock. A very hard-working physician and endocrinologist. I just listened to her talk in RSSD also. All these are possible. Any part of the world we are able to reach. This digital platform does not have any boundaries. Actually, we were able to cross the boundaries of our own states in India. But in the last 6 meetings, we have crossed the boundaries of India too. We are into South Asia countries. And I have been stressing that we should become global. We are likely to close this API DIAS digital programs by 31st of December with 30 programs. Before we close, I am confident we will be able to reach. Another important, landmark achievement API wants to do that is it should reach to, 100,000 physicians globally. Already 50,000 is over. The maximum number in a single session is about 11,000. Today, I am extremely thankful to Dr. Ajay Khera, who is a public health expert, who has readily, within about 10 minutes, he could show his interest to participate and is with us. We are waiting to hear to him. The scientific program, as briefed by Dr. Srinivas, is an excellent program. It has two important norms here. One is about sleep, which is a commonest problem that we meet in our day-to-day practice, and we are going to listen to Dr. Jagdish Suri on that. We will definitely get a lot of scientific informations. And we have another interesting topic on vitamin D. Vitamin D has crossed the boundaries of a simple vitamin and bone marrow. It has got an endothelial and an immune booster, a lot of other active, biological effects of vitamin D have come to stay. I am sure with the knowledge and expertise of Dr. Usha, we will be definitely upscaling our knowledge and skills so that the care that we are going to offer to our patients on these two arenas will be definitely much better than API DIAS digital program. A great success, and I will also stay in line with you all. Thank you very much. Thank you very much.
Thank you, sir. Thank you for your kind words. I'm sure under your able leadership, with assistance of dynamic secretary like Dr. Mangesh Tivaskar, you will cross the borders. You have already crossed. We say after above the 7 seas, you literally crossed it. I'm sure with all these programs. And next is my pleasure to call upon Professor Dr. Shashank R. Joshi onto the dais. And I think he doesn't require any introduction. I'm sure all of us know him very well, but he's the Dean of the Indian College of Physicians currently. He was the IDF Southeast Asia Region 2021, and he's been a fellow of several medical societies, including the American College of Endocrinology, American College of Physicians, and Royal College of Physicians and Surgeons. And he's published about 100 books and monograms and over 800 research publications so far. And he's been editor of various Indian medical journals, including Indian Journal of Critical Care Medicine, which he founded. And he has received more than 200 awards and the International Clinician of the Year award by the American College of Endocrinology in 2012. And the highest is Padma Shri awardee by Government of India way back in 2014. It's over to you, sir.
You see, it gives me a great pleasure that the academic wing of API is the Indian College of Physicians, and Dr. Arul Raj has taken and continued this API DIAS program, which used to be a physical program, which used to go to almost 80, 90 cities, towns, and parts of India to do skill building, capacity building. He has converted this whole knowledge dissemination exercise into a digital platform. The two main thrust areas which I want to talk is, one is the telehealth and telemedicine, which he very nicely said that today is the era to adapt and learn skills. We need to use technology right up to artificial intelligence in its best way. And second key is the patient to physician communication also is going to use the same telemedium. And therefore today the key is, the word is the tele. But at the same time, we should not get digitally intoxicated. And I always say in all my programs that you should do a 2-hour digital detox every day. At the onset, I really congratulate Dr. Arul Raj for wonderfully crafting this program. And my very close brother, Dr. Mangesh Tivaskar, very astute Secretary General of Association of Physicians of India, with the help of our Team Abbott. Let me tell you something about Team Abbott. They have virtually had no influence on this program. This is a completely unrestricted grant from them, and they have allowed us to take topics which are useful for the practicing physician and the clinicians, so that they can not only learn, but whatever they learn, they can adapt it into their day-to-day practices. And that is so critical and vital in today's times. Also, what is useful is that we need to recognize that healthcare is soon going to get digital, and it is going to become a interactive digital platform, and which is what we are using today, and that is something which is very, very pertinent in the today's era. We also would like to make an effort to capture your feedback and translate it. But the whole aim, as Dr. Arul Raj very nicely said, is that we need to ensure that what you listen, you learn, what you learn, you adapt. And I hope that the various pearls of wisdom in different domains of medicine, which will be spanned over this year, you will learn digitally. And actually, this outreach, which Dr. Arul Raj said, is actually going to reach out to many more people. I was the second president to continue this API DIAS program, but we could reach a finite number. But now with digital health, we can not only reach within India, but outside India. And I would request everyone to make this program into a larger domain so that more and more people can listen, learn, and adapt.
Thank you, sir. Thank you for your words of wisdom. And now it's my privilege and honor to call upon Dr. Ajay Khera onto the dais, please. Sir holds expertise in program management and is a specialist in epidemiological surveillance and outbreak investigation, communicable diseases. He has published more than 50 articles in national and international journal. Currently, he is a country representative at Engender Health India, and he has previously held the position of Deputy Commissioner for the Child Health Program at the Ministry of Health and Family Welfare, Government of India. He's also been in charge of the adolescent health programs, and is a medical graduate with a PG qualification in public health with more than 25 years of experience in public health programs at the national levels. And previously, he has worked with the National AIDS Control Organization, Government of India, National Integrated Disease Surveillance Program, and the National Institute of Communicable Diseases. Over to you, sir. For the chief guest address, I'd request Dr. Ajay Khera.
So, thank you very much, Dr. Srinivasan Nivasmurthy, for introducing me. Very good morning and very good evening to all of you. And we have with us Dr. Arul Raj, the president of the API, Dr. Joshi, Dean, ICP, and Dr. JC Suri, I can also find. And then, we have the Dr. Arul Raj, I've already said, and the members of the API from across the country. So I'm really, pleased to join this inauguration ceremony of this continuing medical education initiative, which has been started by API and the Abbott, which is known as the API DIAS, appears to be a very interesting approach to reaching to a large number of physicians. And particularly during this, unprecedented time of COVID pandemic, where we are really struggling to contain this problem of COVID, the role of physicians and sharing of knowledge among physicians is very critical. And particularly, using the digital platform is of paramount importance. And I'm so pleased to note that this appropriate technology, which is called as the COVID safe technology, is being adopted by this association along with Abbott for sharing the knowledge and the information. And actually this digital technology has made the things in the whole world is like, one village, which is called as, global village kind of a concept. I think that kind of a feeling comes, once you start using this technology. And I also understand that a series of, 30 webinars has been planned, starting from the middle of 2020. And today the scientific session is on two important areas. One is that sleep disorder, and another I heard is the vitamin D deficiency. So these are the two important topics which are going to be discussed. And to my understanding, both these problems have become actually very common. And the reasons are all well known because of the lifestyle changes, and particularly in the urban areas. And there's inadequate sleep, vitamin D deficiencies. And this is also, linked with the number of, disorders. The problem might look, very simple, but it has implication on variety of non-communicable diseases. And sleep basically re-energizes the person. So understanding sleep disorders, how to manage them will be very important for physicians to know. Now, in the context of vitamin D, I would like to share some of this observation, which you might be of interest to you. Recently the government of India conducted across the country, there is something called as the Comprehensive National Nutrition Survey, where we have tried to understand the micronutrient level deficiency in the population. Because generally, we try to understand micronutrient deficiency in terms of clinical presentation. But here, the blood samples of around a lakh of people were taken, and the micronutrient assessment was carried out using the laboratory. And it was astonishing to note that the vitamin A D deficiency in the adolescent population, ranged from 15 to 20% in the different parts of the country. And many of them might be asymptomatic, but they might be at the verge of getting those symptoms. So I think this vitamin D deficiency has become a huge problem. And to my understanding, I hope that this particular scientific deliberations from the expert in the field will help in improving the knowledge among physicians and thereby improve clinical practices for the overall health and improvement of the population. So with these few words, I stop here, and I will again like to convey my best wishes to the API and the Abbott for organizing this important continuing medical education using the power of technology. Thank you very much.
Thank you, sir. Thank you very much. We really appreciate your words of wisdom, and it's always a privilege for us that you are here in our program. Thank you very much, sir, again. And now I call upon Mr. Rajshekhar Akkaraju, who is the Director and Head Quality of the India region for Abbott. And he's been Regional Director and Head since 2014, Head of Quality. He has over 25 years of wide and rich experience in the overall quality management, and he's so far worked in the top pharma companies like Dr. Reddy's, Ranbaxy, Zydus, Pfizer, etc. And he has a wide exposure to quality control, as I said earlier, with the quality assurance systems, regulatory compliances like audits like FDA, WHO, etc. And he is a valuable member of international and national pharma professional organizations like ISPE, PDA, IPQ, etc. Over to you, sir, to reiterate our relationship of API and Abbott. We're really happy and privileged to have you as our partner, especially in this science endeavor we are conducting from last 2013 onwards. Over to you, sir.
Thank you, Dr. Srinivas. Good evening and pranam to all healthcare professionals and eminent doctors. Welcome to API DIAS. I will take you through Abbott corporate information for the next 9 to 10 minutes. Slide 1, please. Abbott is a global healthcare leader, having employees of more than 100,000 around the world, serving humankind in 160 plus countries, and we have been in the business for more than 130 years. Abbott is one of just 52 companies from the Fortune 500 to remain on those lists even today, with a sales turnover of around $32 billion worldwide. We have a market-leading businesses and products in medical devices, diagnostics, nutritionals, and pharmaceuticals. Next slide. Abbott's fundamental goal is to help people live fuller, healthier lives, maximizing their potential at all stages of the life. As you know, we have different divisions which drives this company purpose. Our medical devices use advanced technologies to keep hearts and arteries healthy. We have nutritional products which build and maintain our health from infancy onwards. Our diagnostics provides information to guide effective treatments and decisions for HCPs. Our branded generic medicines help people in emerging markets to get and stay healthy. Next slide, please. We have market leading positions in every one of these businesses I mentioned before. Abbott is number one in stents, valve repairs area, heart pumps, heart failure monitoring, chronic pain devices, point of care devices, blood and plasma screening, and adult nutrition, pediatric nutrition, and many in medicines for pancreatic enzyme, progesterone, and hormone therapies. Next slide. As you know, Abbott is a world leader in medical devices. We have broad portfolio of advanced healthcare technologies. For years, our medical device businesses have offered technologies that are faster, more effective, and less invasive. Today, we are focusing on personal technologies that empower people with the data and knowledge they need to help live longer. Our connected care and digital health tools, from mobile platforms to wireless implants to wearable sensors, are helping people and their healthcare professionals make better, faster, and informed decisions. Next slide, please. In diabetes care, our focus is on providing accurate results faster to more people and with greater convenience. So people who have to monitor their glucose levels with a minimum pain. We are world leaders in glucose monitoring. Our next generation sensing technology, like the Freestyle Libre system, is a life-changing innovation. The Freestyle Libre users can get a glucose reading plus record the trends in their levels by just swiping an app-enabled smartphone over the sensor. I think it is a fantastic innovation by Abbott, and it has been available almost the entire world now. Next slide, please. We are committed to bringing the benefits of our trusted medicines across multiple therapeutic areas. You name gastroenterology, women health, the cardiometabolic, the pain management, the central nervous system area, the respiratory, vaccines, and infection areas. We are there in almost all therapy areas. The diverse portfolio includes the world-leading medicines for pancreatic enzyme deficiency, hormone therapy, and vertigo, etc. Next slide, please. So if you look at our branded generic medicines, we span across in India, in this business, we differentiate ourselves from the pure generic companies and our competitors in many ways through our exacting quality standards, the reliable safety and efficacy of our products, the superior clinical services, most vast product range, and patient-centered innovation. We also offer the digital services through the digital platform that gives patients and healthcare providers the required tools, the tips, and resources to better manage people's health. We also offer market-specific portfolios that reflect the health needs of each region we serve, with a special emphasis on the core therapeutic areas where there is unmet medical need. Next slide, please. Abbott present in India more than 110 years now, leaving a remarkable legacy in providing healthcare solutions to our customers, doctors, and patients. We have 3 manufacturing plants in India producing pharmaceuticals and medicines and nutrition products. We have 1 Innovation and Development Global Excellence Center in Mumbai to provide tailor-made innovative products to Indian customers. Next, please. So Abbott has pioneered innovative ways to screen, diagnose, and monitor a vast range of health conditions with greater speed, accuracy, and efficiency. As a result, we have become a leading name in immunoassay diagnostics, blood screening, bedside testing, and companion diagnostics that provide information essential for the use of corresponding medication or treatment. Abbott is a market leader in test and instrument systems for hospitals, labs, blood banks, and clinics. Abbott has also become a leader in testing in the fight against COVID-19. developing multiple tests to detect the virus and antibodies to the virus. Next slide, please. Abbott has been named by Fortune magazine as one of America's most admired companies every year since 1984 and ranked the #1 company in our industry for the past 7 years. This honor is the result of excellence across the company. Abbott was ranked as the industry group leader on the prestigious Dow Jones Sustainability Indexes for the 7th consecutive year. It is the 15th year in a row we have been named to the index. We were named to Fortune magazine's list of best big companies to work for in 2020. We have been named one of Diversity in top 15 companies for diversity for 16 straight years. We have been also named one of the best places to work in more than 25 countries. Working Mothers magazine has selected Abbott as one of the top family-friendly workplaces in the US for 19 consecutive years. So there are many, many accolades like this. Is a big list. Next slide, please. Abbott has been helping people live more fully for more than 130 years. We value achievement and the perseverance it takes to accomplish challenging goals. That mindset is reflected in our sponsorship of the Abbott World Marathon Majors. And it is evident in the way Abbott people approach the important work we do. We are proud of our long history of success, but we are constantly looking to the future, seeking new and better ways to help people live their best and fullest lives. We are strong, focused, and ready for the future. So with this, thank you to all India medical fraternity in supporting Abbott in delivering their purpose. Thank you very much, and over to you, Dr. Srinivas.
Thank you, sir. I think it's a long journey, 130 years, it's still going strong. And thank you, everyone. And I think, thank you, everyone. And we are done with our inauguration program now. And let us move on to the main part of the program today, that is our scientific sessions. We have two wonderful sessions. One is talking about the sleep and the physical well-being, the mental well-being, and updates on insomnia. The other one is the vitamin D, comorbidities, and the latest technology in the vitamin D as well. So the first session is by none other than Dr. Jagdish Chandra Suri. And Sir has been the Director and Head of Department Pulmonology, Critical Care and Sleep Medicine at Fortis, Vasant Kunj in New Delhi. He's been a former consultant professor and Head of the Department of Pulmonary and Critical Care, Sleep Medicine. He's been a member of the expert committee constituted by Ministry of Health and Family Welfare, Government of India, under the chairmanship of DGHS, to review the National Clinical Management Protocol for patients of COVID-19. So he's got a huge contribution in the current pandemic as well. And he's been a member and advisor for the National Task Force on COVID-19, H1N1, flu vaccination, asthma, COPD. So the list is never ending. And it's our privilege to have you, sir, for this wonderful topic, which most of us lack personally and professionally also. The sleep is related to our profession also. And that is one of the commonest ailments we come across in our routine practice. And we fail to recognize and treat accordingly and end up with the complications with many of our patients. So over to you, sir, for your deliberation.
Thank you, Dr. Srinivasan. Thank you for the nice introduction. And thank you, Abbott. Thank you, API for this kind invitation. I am really overwhelmed and privileged. Today, I am going to talk to you about a very important subject, that is sleep. Because sleep, as you know, we spend 1/3 of our lifespan. So it has to be a very important area, which I would like to cover. I'll talk about normal sleep and how sleep deprivation affects our physical and mental well-being. Then I will be giving you some overview on insomnia. Is my slides visible? Are my slides visible?
Yes, sir. Yes, sir.
No, do I have to share it? Because I can't move my slides.
But we can see, sir, just change it, sir. Yeah, it's changing.
It's changing, no? Just
Yeah.
Okay. So what is sleep? Sleep is an extended bout of rest we experienced on a daily basis, where we are unaware of what is going on around us. Though outwardly our brain looks silent, but all our nerves and muscles, though they go into rest and in the recovery phase, but the sensory input is going on. The brain is aware of all the sensory information around us. Sleep is an active period, as against people used to think previously that it is a timeout, it is a inactive phase. But now we know that sleep is an active period in which a lot of important processing, restoration, and strengthening occurs. I'm not able to move my slides.
It's changing, sir. It is
I
changing.
think
You just need to tell me.
please allow me to share my presentation from my laptop. How we define? Can you see now?
Yes, sir. Yes, sir.
Yes, sir.
Go ahead.
So how to define sleep? There are two ways we can define sleep. One, by the behavioral changes which take place when a person goes to sleep. That means the person is in reclined position, he has closed eyes, decreased movement, decreased response to the internal and external environment, but it is reversible. The person can be roused from sleep. It is different from coma, where the person cannot be roused from that state. The sensory information is continuously processed by the brain, and we all know that sleep is physiological, it is necessary, it is temporary, reversible, and cyclic. The other way we can monitor or define sleep is through neurophysiology of brain. And if you monitor the electroencephalogram of patient during sleep, the normal people during sleep, you will see that it has two stages. One is what is called non-REM stage, and the other one is a REM stage. Now, the non-REM sleep is divided into three stages: stage 1, 2, and 3, with the increasing depth and the REM sleep. Now, here you can see from this hypnogram, this is our normal sleep period, which is say for 8 hours. So when we move from wake to sleep, you can see here that we enter the sleep through the non-REM sleep. At the upper one is the REM, so non-REM sleep, and then with a very short period of stage 1, we go into stage 2 and then go into stage 3. And after that, we come back to stage 2 for a short period and straightway go into first phase of REM cycle, REM sleep. So one cycle of sleep is stage 1, stage 2, stage 3, and REM. It constitutes as one cycle. And then we have the second cycle, the third cycle, fourth cycle, and fifth cycle. The first cycle is usually the shorter, which is about 90 to 20 minutes, and the subsequent cycles are between 110 to 130 minutes. The important thing here is that if you see the deep sleep, the stage 3 which you call as the deep sleep, and stage 1 and 2 is called the light sleep. So non-REM has the light sleep, stage 1 and 2, and the deep sleep as the stage 3. And then we have the REM sleep. So you see that the most of the deep sleep, which is stage 3 here, occurs in the first 1/3 of the sleep. And on the other hand, if you see the REM sleep here, it progressively increases as the sleep progresses in the night, and you will see that most of the REM sleep occurs in the last 1/3 of the sleep. So we have this way about 4 to 5 cycles lasting from say 110 to 130 minutes, and where a person enters from wakeful state to light sleep, which is stage 1, 2, and a person can be easily woken up during this stage. And then we go to deep sleep, which is stage 3, and a person is difficult to wake up. And even if a person is made to wake up, or if he arouses from stage 3, there is significant sleep inertia, and the person may feel disoriented. And then we have the REM sleep, which is a rapid eye movement sleep, which is also called the dream sleep, because here the brain is active, our muscles are totally paralyzed. So it's an active brain in a paralyzed body. Because most of the dreaming occurs in this stage, the nature has made us such that when we are dreaming, we should be paralyzed so that we don't start enacting our dreams. So if you start enacting your dreams in sleep, this is a condition called REM sleep behavior disorder. Now, how is this sleep distributed, the various stages distributed in sleep? The stage 1, which constitute only 3 to 8%, it is basically a transition sleep. So it comes when the person goes from wake state to sleep state. The stage 1 is a kind of a transitional sleep. And then most of the sleep you can see is stage 2, stable light sleep, which constitute about 50% of the total sleep period. And then we have stage 3, and the previously it used to be called stage 3 and 4. Now we call it stage 3. It's a deep sleep, and this is responsible for physical restoration. You know, when we are working during the day, we are physically tired, we are mentally tired. So sleep is a process of both physical and mental restitution. So deep sleep is basically associated with physical restitution. And then we have the REM sleep, where most of the mental restitution takes place. It also constitutes about 20 to 25% of the total sleep period. In this, learning and memory consolidation occurs, the cognitive functions improve, the moods stabilization occurs. So all the mental, psychological, and the learning processes are preserved during this stage of the sleep. So how does the sleep propensity changing during the day? Now, how do we decide that when we should be sleeping? So this is what we call as a two-process model. So what this two-process model is, one, we have what we call the homeostatic drive. The homeostatic drive is the least when you wake up in the morning. So when you wake up in the morning, you are least sleepy because you have slept, if you have slept well. So during the day, as the period you are awake increases, your propensity to go to sleep increases. So the homeostatic drive increases throughout the day. On the other hand, you know, there is a signal from our clock. There is a clock, what you call the master clock in our brain, which is there in the suprachiasmatic nucleus, and that gives direction to the body when we should be sleeping. And usually this does it under the control of light. So when it is the day, this clock gives signal to the body that we should be awake. And you can see here below that as the day progresses, the signal or the alertic signal starts increasing, and the homeostatic pressure to sleep also starts increasing. And we know that during the day we don't feel sleepy at all because the alertic signal and the homeostatic signal cancel each other. So you can see that just before sleep, our circadian signal is at the maximum, and also our homeostatic signal to sleep is also maximum. So they are almost cancelling each other. So you don't feel sleepy even half an hour before you actually go to sleep. So once we reach our sleep time, as you can see here, it is dark. It is around 9 p.m. or 10 p.m. So during the dark, there is a release of melatonin. And this melatonin hormone actually has two receptors, and then this actually stimulates sleep. So when melatonin is released in sufficient quantity in dark, then there is a increased homeostatic drive also, and these alerting signals are completely inhibited by melatonin, and we immediately go to sleep. So you take just 15 to 20 minutes to go into sleep when this melatonin occurs. So it's very, very important that when we want to go to sleep, when actually it is the sleep time, our light in our room should be very, very minimal, because if the light is very strong, or if you are working on a computer or a laptop, or you are using mobile phones, the blue light which is coming will suppress this melatonin production and will delay your sleep onset. So the timing of sleep is guided by the two processes, what is called the homeostatic drive and the circadian drive. And the best sleep you will get is when both of them synchronize, the homeostatic drive and the circadian drive synchronize. Suppose you are doing a night duty and you go home in the morning, and at that time, suppose you want to sleep, the circadian alerting will be very high. So this will be the circadian signals and the homeostatic signals will not be in sync, and you won't get a very good sleep. So what are the other important the things which happen in sleep, the physiological changes? The most important thing is that sleep is a state of cardiovascular relaxation. Here, during this period, the heart rate comes down, the blood pressure comes down, the cardiac output decreases, the cardiac load decreases, and this is mainly because of increase in the parasympathetic activity and significant decrease in the sympathetic activity. So this is the most important thing. That is why your blood pressure drops by 10%. So what we call as nocturnal dipping. And then our ventilation also decreases, the minute ventilation decreases, the tidal volume decreases, the respiratory rate may be preserved. So overall, there is a decrease in the minute ventilation. And also there are other factors like gastric acid secretions, gastric motility, swallowing, salivary flow, all these things decrease. The another important thing which happens in sleep is the penile tumescence, and you will see that during REM sleep, there is penile tumescence, and that is a very important finding, and the physiological significance of this we do not know. And those people who lack REM sleep due to various sleep disorder, this penile tumescence is not there, and this may be responsible for development of organic impotence. So why is sleep important? As I mentioned to you, sufficient sleep is essential for maintaining optimal physical health, mental and emotional functioning, and cognitive performance. Inadequate sleep, whether due to sleep deprivation or due to insomnia, and poor quality sleep due to various sleep disorders like sleep apnea, restless leg syndrome, interfere with the quality of life and can be hazardous to health. So you can see that sleep deprivation can affect cognitive and physical performance, learning and memory consolidation may be affected, mood may be affected. Most of the people who are sleep deprived may have a low mood and are more prone to develop depression. And the another important thing is that our immune functions are also stimulated, and they are preserved during sleep period. Sleep and immune system is a very, very important thing, because a good night's sleep is also important in maintaining our immune functions and our ability to fight bacterial and viral infection. We say that sleep is a natural immune booster because it helps in the production of T cells, which play an important role in developing immunity against viruses. So a good night's sleep also improves the response time of the immune system to viral infection. And in a recent study, it was found that when people who are exposed to a common cold virus, and if they are divided into two groups, the one who has a sleep period of more than 7 hours and the other group who has a sleep period of less than 7 hours. So those who had a sleep of less than 7 hours are at a higher risk of developing common cold once they are exposed to the common cold virus. So sleep is a very, very important factor in the overall functioning of our immune system. And we have seen that people who are sleep deprived, those teenagers who are particularly working during the night, you see that they are more prone to develop viral infections. They are more prone to develop tuberculosis and other chronic diseases. So what are the recommendation of our daily, how much should we sleep? And according to National Sleep Foundation, this period, the amount of sleep which we should have for optimal functioning decreases over a period of time. As in the newborn, it is actually something between 14 to 17 hours. Most of the newborns are actually are spending their time sleeping. They only wake up in between for feeding and for cleaning, and rest of the time they are sleeping, and they have about 50% of the time they have got REM sleep. And this is important for the development of brain, because the newborn when they are delivered, their brain is not that developed, and it takes some time for the mental functions to evolve. And then as the child grows, the need for sleep actually comes down. And in adult period, we need about 7 to 8 hours of sleep. In fact, 7 to 9 hours of sleep, and so the average is 8.5 hours. So how much time we should sleep? There is actually a wide variations. American average, if you see, it is 6 hours and 40 minutes. Most of the people, though, desire 40 more minutes to sleep if they are asked to. The societal pressures, as we know, the jobs, the 24-hour society, and the other thing is contracting our sleep time. The ideal sleep time from various epidemiological studies which are required for optimal functioning of our body is about 8.5 hours. Because if you look into the impact of sleep period on mortality, if you can see here that the mortality actually increases as the sleep period decreases. You can see here the H shows this thing. As the sleep period decreases from 8 hours to 7, 6, the mortality goes up. And also when your sleep period increases above 10 hours, that shows that your sleep quality is poor, and this can be due to various sleep disorders like sleep apnea or restless leg syndrome. So sleeping less is also increases the risk of mortality, and sleeping more also increases the risk to mortality. So the consequences of sleep deprivation: once in a while, if you are not able to sleep well due to any reason, you may at best feel tired the next day, but it is not going to affect your health. But it is the perpetual sleep deprivation or lack of sleep over periods of weeks, months, then it is going to affect the health. And what you will see that most of these people feel tired all the day, they drop off, they feel sleepy, difficult to concentrate, hard to make decisions, their cognitive functions are low, they feel actually low in mood, and also over a period of time, they actually start to worry about not being able to sleep. So there are physical effects like increased appetite. That is why these people become obese. There is a weight gain. There is a temperature dysregulation. There is shakiness, headaches, increase in the pain sensitivity, and decrease in the immune functions. Psychological effects, very common, people who have not slept well, you know it, you observe it, they are more irritable, they have poor concentration, they are aggressive, they have apathy, time and place disorientation, depending upon the duration of the sleep deprivation, loss of emotional control, they can throw fits, and of course they have excessive sleepiness. As I mentioned to you that during deep sleep, we have a state, we have increase in the vagal tone. It's a parasympathetic state. The sympathetic tone goes down. There is an increased production of growth hormone, increased production of insulin, and there is a decrease in the cortisol production. So if there is a sleep deprivation, there will be increased sympathetic activity, there will be decrease in the insulin production. So you'll have impaired glucose control, increased cortisol production, increased blood pressure, increased sympathetic activation, increased appetite, as I've told you, increase in the C-reactive proteins. So all these data suggest that sleep restriction may actually have health consequences, like they become obese, diabetic, and have cardiovascular consequences. So there are some studies which shows, that the risk of developing various cardiovascular diseases. Here you can see that there is an increased risk of hypertension, coronary artery disease, acute myocardial infarction, diabetes, impaired glucose tolerance, and increased risk of diabetes if the sleep period decreases less than 5 hours. You can see here again the relative risk of developing diabetes, and you can see here, the hours of sleep here. You can see with 8 hours of sleep, the relative risk is 1, and as the number of hours you sleep during night decreases, the relative risk increases for the development of diabetes mellitus. And of course, those people who are sleep deprived are at a very high risk of having excessive daytime sleepiness. They have a poor quality of life, and they are at a risk of serious car crashes, injuries, And about 20% of all the car crashes, injuries in general population are associated with drivers' sleepiness. So what are the other factors which can affect sleep? The factors can be medical diseases like heart failure, COPD, if patient has pain, breathlessness, and then psychiatric diseases like depression and schizophrenia. It is very important here to mention that the neurotransmitters, which are responsible for our mood, and if they are deficient and leads to the development of depressive illness, these same neurotransmitters are also involved in the control of sleep in the body. So sleep disorders can also interfere with the sleep, like sleep apnea and narcolepsy. Certain medications like antidepressant and substance abuse like alcohol, caffeine, maybe and tobacco smoking, they are also associated with disturbance of sleep. And of course, lifestyle things like voluntary sleep restriction, shift work, jet lag, and travel. All of these are associated with this thing. So here now I will give you some update on insomnia. How do we define insomnia? Now there are 3 things which one has to understand. That there can be difficulty in starting sleep, so what you call sleep onset insomnia. There can be difficulty in maintaining sleep, so sleep maintenance insomnia, or there can be early morning awakening. So if you are waking up earlier than your usual time, and if this occurs despite adequate opportunity and circumstances for sleep, that means we must differentiate it from sleep deprivation, which is a voluntary thing, and then this must result in some form of daytime impairment. So the definition is when you have difficulty falling in sleep for more than 30 minutes, because the normal sleep latency is between 15 to 20 minutes. When a normal person who has normal sleep, normal daytime functioning, goes to bed, takes usually 15 to 20 minutes. And if the time goes beyond 30 minutes, then it is sleep onset insomnia. Difficulty in maintaining is when there are frequent arousals during the sleep. You can be seen in people who take alcohol and with the sleep apneas. Early morning awakening is at least more than 30 minutes before your usual time. We call it early morning awakening. And then it should be associated with consequences in the next day. And these consequences can be in the form of fatigue, malaise. There can be a problem with the concentration. There is memory impairment, daytime sleepiness, or the person has headaches, gastrointestinal symptoms, and also if there are history of accidents or near-miss accidents. So these are the consequences, which is very important. And when these consequences are there, we call it insomnia disorder. So if you have those kinds of symptoms which I mentioned to you, and there are no daytime consequences, then it is not insomnia disorder. You can also, for the definition of insomnia, we should also include the frequency and the duration. So these symptoms should be there at least 3 times a week, and it should be there for more than 3 months before we call this patient having chronic insomnia. Now, insomnia can also be classified as transient when it is associated with sudden stresses, examinations, fever, hospitalization, some professional setback, or it can be chronic, which is lasting for more than 3 months, which is associated with depression or other medical conditions like COPD, congestive heart failure. Patient is having chronic painful conditions. So they are, we can put it like that. So how common is insomnia? How prevalent is insomnia in the general population? And it has been seen through various epidemiological studies that about 10 to 15% of the general population has significant chronic insomnia. In fact, it can be there in patients with medical conditions. It may be even 20% or even more. Patient with cardiac diseases, the prevalence of insomnia is to the tune of 40 to 50%, and the highest incidence is actually seen in elderly population and in postmenopausal female. So you can see that as we grow older, the incidence of sleep-related complaints or insomnia increases, and it is for each age bracket. It is more common in females than in males. And it is very important to know that as we grow older, we also develop other problems like dementias, memory lapses, and these are the patients, who may also have a very high incidence of insomnia. And they may not actually come to their doctors with the complaints of insomnia. They may be coming with other problems related to their cognitive functions. And it is important to look for insomnia in these cases. And not only we have to detect, because we have to treat it very effectively, because it's very, very difficult to treat insomnia in these patients because they are not able to appreciate this problem. And we have here some important studies from India. Again, the prevalence varies from 47% depending on the type of population we are taking for studies. So what are the causes? Before you actually evaluate a patient of insomnia, it is very important to know what are the common causes of insomnia. You can see here that about 2/3 of the patients have either a primary behavioral problems, psychophysiological problem, or they have psychiatric illnesses like anxiety or depression. And then the other important causes include common sleep disorders like restless leg syndrome, periodic limb movement, circadian rhythm disorders. Because as we grow older, our sleep phase actually shifted forward. So in teenagers, you will see that they tend to sleep later and wake up later, and their sleep cycle shifts from normal 11 to 7 to say 2 to 9 or 3 to 11, and that circadian shift we call delayed sleep phase syndrome should be recognized before we label them as patients of insomnia. Then sleep disorder breathing, substance abuse, and other conditions are common. So it's very, very important to know the causes in the primary psychophysiological. We have the sleep deprivation. So these are the important factors, because once we look into them, we may be able to treat insomnia in most of these cases. The other important thing here you can see is the disorders and anxiety disorder, and it is very important to recognize this if as a cause of insomnia before we start treating them, because if the patient has depression, then we have to treat the depression, because the insomnia is a symptom of depression here. And not only it is important to diagnose it, but we also have to select antidepressants, because depression may present either as insomnia or as excessive sleepiness during the day. And those patients of insomnia, those patients of depression who are presenting with insomnia need sedative antidepressant rather than the SSRIs. So you can see here the relative risk of psychiatric disorder. So those patients who are insomnic are also more prone to develop psychiatric illnesses like depression, anxiety, and they are also more prone to substance abuse and panic disorders, OCD, and this thing. So it is a bi-directional relationship. Depression can lead to insomnia, and the insomnia is associated with various psychiatric disorders. Now, you can, from the type of insomnia, you can actually know the causes. Those patients who are primarily presenting with the sleep initiation insomnia, that means they have difficulty in getting into sleep. They are the who have primarily anxiety disorders, restless leg syndrome, or also it can be due to drugs. And those patients who get into sleep easily, but they have frequent arousal during sleep, and these are the patient who may have primary sleep disorders like obstructive sleep apnea and poor sleep environment. That means a lot of noise is there, temperature is not optimum, and the temperature is not good. So these are the condition, and also patients with depression may also have difficulty in maintaining their sleep. Early morning awakenings are the patient again with depression. So in order to understand how insomnia develops and how insomnia evolves. Now, these important things I would like to highlight to all the physicians, that once you are evaluating a patient with insomnia, you must understand and find out in your patient that what exactly is causing insomnia and how we should approach them. So to understand that, understand the pathophysiology of insomnia and of insomnia, we must understand this 3P model, what we call predisposing, precipitating, and perpetuating factors here. We can see. So the predisposing factors are the factors which are there in people. That means everybody will not develop insomnia in a given circumstance. The people who are predisposed to develop insomnia are the one who are likely to develop insomnia in a particular situation. And these predisposing factors are usually the presence of anxiety and depression, and also in many cases the lifestyle changes, decrease homeostatic pressure to sleep, which what we see in older people, and their sleep drive is low. So these are the people, those who worry a lot, who are anxious people. So these are the predisposing factor. And then we have the precipitating factor, which can be in the form of acute stress. It can be an illness, it can be trauma, it can be pain, it can be hospitalization, it can be professional setback, or a loss of a close family members, shift work, or even travel. This thing. So these are the precipitating factors are there. And then the third thing is that once this precipitating factor goes away, and if patient continues to be still having insomnia, it is due to the perpetuating factor. And these are basically some maladaptive thinking which we acquire during the initial phase of insomnia. We actually these include poor sleep hygiene, intake of alcohol, taking too much of tea or coffee, or becoming actually conscious about your sleep. That once you don't sleep for a few days, you become conscious of the fact that you're not sleeping well, and then you start worrying about sleep. And once you start worrying about sleep, the moment the sleep time comes, you become too anxious and you go into a state of hyperarousal. So these are the factors which will cause perpetuation of our insomnia. So these factors are too much time awake in bed, going to bed too early in an effort to increase your sleep time, or staying in bed too late in the morning, trying to compensate for sleep during the day. So these are the changes which you develop. Fear of not sleeping. You may think that if you won't sleep, you will develop some health consequences, and some unhelpful beliefs and misconceptions about the sleep and insomnia. That's what I told you, and the hyperarousal and the inadequate hygiene. So this model is the most important thing if I am able to convey to insomnia as a whole and the approach to management. What we say, so you can see here at this line at 60, this is what we call as the threshold for insomnia. So if your intensity goes above this, you are having clinical insomnia. So in the pre-insomnia phase, you have the predisposing factor, which I told you, which is anxiety and depression. This patient have these things, but still not develop insomnia because he has to reach to this level. And then there is an acute precipitating event, which I told you, which can be illness, which can be stress of any reason, and it crosses above, and then the patient goes into acute insomnia. Now, during this phase, the person becomes conscious about sleep. If this phase becomes a little longer, so you develop this perpetuating factor, and ultimately after some time, both their precipitating factor become much less important, and it is the perpetuating factors which keeps the insomnia on. So when we are thinking of when you are thinking of treating this patient, the drugs may have a role only in the initial phase, and the cognitive behavior therapy is the most important thing in treating chronic insomnia, because this is what we have to address is the perpetuating factors, which may not be affected by the drug. So the management part, we have the most important thing are the drugs, which we have the Z group of drugs or the benzodiazepine receptor agonist. We have the cognitive behavior therapies, the melatonin receptors. The treatment which are not endorsed due to limited evidence or efficacy are the antihistaminics or complementary and alternative prescriptions. So this is what I was mentioning to you, that when you are thinking of these drugs, the Z group of drugs or benzodiazepine receptor agonists, they may have some role in the acute phase when the major component is the precipitating factor in the background of premorbid predisposing factors. So once this phase prolongs, most of the patient may actually recover during this phase and go back to their premorbid condition from year to year. But those patients who have a tendency to go into maladaptive thinking, or those who have a poor sleep hygiene, they will now start having these perpetuating factors. And ultimately, you can see here that the precipitating factor has become much less. The patient has recovered from illness. He has overcome the stress or the professional setback, or the loss of a near one. He has overcome that feeling, but his perpetuating factors are there to keep his insomnia alive. And for this, you have to use the cognitive behavior therapy. And what are these methods? We have what you called the behavioral methods, in which we have sleep restriction, the stimulus control, and relaxation methods. The basic idea here is that we want to reduce the excessive time in bed and irregular sleep schedules, and the sleep incompatible activities at the bed, and also those activities which cause hyperarousal. So these are the behavioral methods. And then we have cognitive therapy. We are trying to basically correct patients' unrealistic sleep expectation. That means that he has for 8 hours. So we have to tell that even if you sleep for 7 hours, it probably will not make much difference. So they start thinking too much about sleep and its consequences, misconception about sleep, and sleep-related worries and poor coping skills. So these are the things we have to do through the cognitive thing. And then the educational methods like sleep hygiene education and giving them appropriate information about sleep. So these are like restricting the use of caffeine, alcohol, tobacco, telling them doing regular exercises, and improving the environmental factors in sleep. So you have these techniques. I don't have time to go in detail. Actually, these are actually weekly sessions, and we have to have about 6 to 7 sessions of cognitive behavior therapy before we get some significant factors in this thing. So these are stimulus control therapy, sleep restriction, cognitive therapy, relaxation training, circadian rhythm. So this is a structured program of cognitive behavior therapy which we do. And the important thing in this is that we restrict the time in bed to actual sleep time. Suppose a person is in the bed for 10 hours but is actually sleeping for 6 hours. So we restrict the time in bed to 6 hours so that the sleep efficiency is improved. We tell the patient to go to bed only when they are sleeping, and if they are not able to sleep within 15 to 20 minutes, they should come out of the bed and go to another room and start doing some boring activity, can read a book, and once they are feeling sleepy, they can come back to the bed and sleep. So they should, besides that, even if they have to do it number of times in the night, they go to the other room and come back and try to sleep. They should get up at the same time every morning, and they should any naps during the day to decrease their homeostatic pressure to sleep. So the basic objective is to reinforce the association between sleep and bedroom stimuli and establish a regular sleep-wake rhythm and strengthening their homeostatic drive in this thing. The sleep hygiene methods, the most important thing is we tell them to avoid watching the clock, because if they are, whenever they wake up and see the clock, they become too worrisome that it is only 2 o'clock in the midnight and they have not been able to sleep, and what will happen in the next day. So we tell them not to watch the clock, avoiding the stimulants like caffeine, nicotine, particularly near the bedtime, heavy meals, and drinking alcohol within 3 hours of the bed. Exposure to bright light is very, very important during the day. So in the first part of the day, they should expose themselves to good sunlight so that their melatonin secretion is enhanced during the night. But they should avoid exposure before the sleep time. They should enhance their sleep environment, which should be dark, quiet, cool in temperature. The temperature should be something around 18 to 21 degrees centigrade. Increase exposure to bright light during the day, practicing relaxing routine just before the time, and reduce time in bed. That means regular sleep and wake cycle and regular exercises. The drugs, just 2 minutes, 2 slides, I will complete. The important thing which I want to mention is the role of drugs. As I told you, the drugs may be important only in the early phase of chronic insomnia, because during the in the long-term management of chronic insomnia, it is the cognitive behavior therapy which is more important. And the drugs, we have the Z group of drugs where you have this zolpidem and zaleplon and S-jopicolone. Now these are the drugs, which are now being commonly used, and we have also benzodiazepine, the group of drugs. The important thing I would like the physicians to know is the half-life and the duration of action. So you can see here, the elimination time, that is the half for this Z group is 2.5 hours, 2.8 hours, 1 and 6 hours, here for S-jopicolone. And if you look into the benzodiazepines here, their half-life is very long. So it's very important that when you are giving a drug to the patient, it should not be its duration of action should not be too short that it doesn't cover the total sleep time, and the patient may wake up much before their awakening time, and you have to give a second dose of the drug. On the other hand, the drug should not be too long acting that it should have a spillover effect on the next day. As you can see here, if this is the this dark bar is the sleep time, and this is 24. So if you give a drug whose action is going more than 24 hours here, this is long-acting drugs, then these patients will have a spillover drowsing effect of this drug, and they will feel drowsy throughout the day. So this is also not desirable. On the other hand, if you use this short-acting drug, then their effect is getting lost, because the sleeping effect is on this horizontal line, as you can see here, that the patient will feel sleepy here with the long-acting drug almost 24 hours of the day. Here, you can see here that the sleep effect, the sedating effect will last for only few hours, and it's not even lasting for the sleep period. So this also is not desirable. So we should have a drug, basically, which has a sufficient duration, which should actually cover the whole sleep period, and its level should come down below this line, which is with the sedative, where the sedative effect is not there during the daytime, and it should not affect the quality of life of this patient. So this is the most important thing, when you are prescribing these drugs to your patient, and the duration should be beyond that, So to conclude my talk, I would say that sleep is very essential. As you know, that we spend 1/3 of our lifespan. It is a very important period where all the restorative processes take place. We undergo physical restitution, mental restitution, emotional stability, and hormonal stability, and recognize that we should have adequate period of sleep. This, lifespan where the activities are going throughout the day and night, there is a significant constriction of our sleep time, and this is impacting our health, our physical health, and our mental health. So that's the most important thing. Thank you for your kind listening.
Thank you. Great. Thank you, Dr. Suri. It was one of the fantastic talk. You said the tablet one must choose, which may cover the entire sleep duration. The tablet may cover, may not cover the entire sleep duration, but Dr. J.C. Suri could cover the entire insomnia topic in such a short time. Sir, you may not know, I was your student, and your talks on oxygen therapy, and your talks on sleep medicine, and your talks on various gadgets that we prescribe in our respiratory medicine are so loved one. Even after 20 years, we are following those teachings, and I'm grateful to you for your time. Sorry I could not join earlier, and I did not get the pleasure of introducing you. There was some net connectivity issue from my end. Dr. Srinivas had to do that job, but thank you very much for your presentation. Though I could not introduce her, but I have a pleasure of introducing Dr. Usha Sriram. She's our next speaker, and she's going to be talking about vitamin D. Dr. Usha is consultant endocrinologist and diabetologist. She's a general physician at Adyar, Chennai, and has experience of 4 decades in the field. She practices at Acer Clinic in Adyar, Chennai, and TAG VHS Diabetes Research Center at Tiramani, Chennai. She completed her MBBS from Madras Medical College, Chennai in '78 and a Diploma of American Board of Internal Medicine from American Board in 1983. She is the President of Indian Society of Bone and Mineral Research, is holding important positions in medical societies like Indian Menopause Society, Chennai Chapter, Joint Secretary, Research Society for Study of Diabetes in India, Endocrine Society of India, Endocrine Society of US, American Association of Clinical Endocrinologists. She has organized dozens of professional programs, the most notable being ICARDIA, REPRO, India 2001, EndoPro, PACE 15, and DIVAS 2016. With those words, may I present Dr. Usha Shriram to you. She's going to be talking on vitamin D and associated comorbidities with special focus on nanotechnology. Over to you, madam.
Thank you so much. I hope you can hear me well. First, thank you to Dr.
yes.
Agamwara for your kind introduction. And then, of course, to API, special thanks to Professor Arul Raj and my brother, Dr. Shashank Joshi, and Abbott for organizing this program. And I'm very happy to talk on this topic, especially because as president of the ISBMR, we are committed to promoting awareness about bone health to the community in general, and especially our physician community, because this is one area, just like the previous talk about sleep, just completely filled with lots of questions and debates and confusion. And so I will try my best to, discuss some of those issues. So can I have the first slide, please? And can I have the full screen, or should I do that? Can I have the next slide, please? Okay. Can I have the full screen? Is this the full screen? Okay, this is okay. So, like I said, the topic today is on vitamin D. Especially, we are going to talk about extraskeletal, benefits. So, I don't have the slide on the screen. And can I have the full screen so I'll be able to see the slides? That's my introduction slide. I don't think I need that. Actually, I just want to say that my current affiliation is, I just head the Department of Diabetes and Endocrinology at TAG VHS in Chennai. Okay, so the topic is vitamin D deficiency, particularly in association with extraskeletal challenges like cardiovascular diseases, hypertension, diabetes, immunity, and other things. Next slide, please. So, as you can see, I'd really like a full screen presentation, because these are very small, people may not be able to see it. So just to, say that this has myriad presentations, starting from associations with things like multiple sclerosis, to diseases of the lung like COPD or cystic fibrosis, associations have been reported for cancer, especially breast cancer, but only in postmenopausal women. Also, some association has been reported with colorectal cancer and ovarian cancer. We all know that muscle strength is really important in terms of vitamin D. So grip strength is one of those things that is affected by vitamin D deficiency. And we all know the skeletal benefits, which are really in the forefront, because we always link vitamin D deficiency in the early years with conditions like rickets. Fortunately, we do not see that much of conditions like rickets anymore, but we are seeing an adult version, which is osteomalacia, in a very big way now. So the effect of vitamin D on bone, I think, is extremely well established because of the connection between vitamin D and calcium and parathyroid, and what might happen if there is a deficiency. And then, of course, on top of that, there are even rarer things like allergies. Reported to be associated with certain allergies. Some certain skin conditions like psoriasis has been linked. Mental health is very important. In fact, seasonal affective disorder, or SAD, has been linked with vitamin D deficiency. So and falls, again linked to possibly muscle strength. So when people are deficient in vitamin D, then and muscle strength is low and balance is poor, they may be at increased risk of falls. And conversely, if the vitamin D levels are raised, especially in very elderly patients, the sudden improvement in muscle strength or some other factor makes them actually more prone to falls. So the important thing is to do this in moderation. So as you can see, that this is an important nutrient for the whole body. And we know that vitamin D receptors are ubiquitous, are present all over the body. And the 1,25-dihydroxy, the enzyme, 1-alpha hydroxylation, is present in 10 other tissues other than the kidney. We always thought it was exclusive to the kidney, but it's present in 10 other tissues. So this is a really important nutrient. But the question is, we have plenty of observational data linking vitamin D deficiency and many of these conditions that I've listed. I've not even talked about hypertension or diabetes or immunity, but there's a very clearly links have been established. What has not been very well established yet is, suppose we replace the vitamin D and bring their levels up, does it mean those problems will go away? I don't think that has been established, and probably not entirely true, because all these conditions are multifactorial. But it's important, I think, to optimize vitamin D level for overall improvement of so many things that we have talked about. Next slide, please. So when it comes to our own, next slide. Hello? Next slide, please. No, yeah. So what makes, can you go to the previous slide? I think we missed you missed a slide. Yeah, this one. So do Indian people have sufficient levels of vitamin D? This has been a major, paradox and question in people's mind. We live in a country with not just plenty of sunshine, excess of sunshine. And so why would people in India have such low vitamin D levels, or even have such widespread vitamin D deficiency? This has been puzzling people a lot. Actually, if you think about it, it's not such a big puzzle. Nearly, 75 million plus, 76.9% of Indian people have insufficient vitamin D levels. And surprisingly, the lower age group, 18 to 30 years, when people are supposed to be active and outside, they have a high amount of vitamin D deficiency. And in the genders, that seems to be almost an equal distribution of vitamin D. Next slide, please. So what is causing Next slide. Yeah. What is causing so much of vitamin D deficiency? Diet, increased melanin content of the skin, inadequate sunlight exposure, and lack of food fortification. These are all big reasons for vitamin D deficiency, in addition to pollution. So just first to tell you, vitamin D, our main source is sunlight. And our present lifestyle does not allow people to be out in the sun, and they need to be out in the sun somewhere between 10 a.m. and 3 p.m. or somewhere in that time frame, when the UVB rays are maximum, the zenith angle and the UVB rays provides us with the maximum vitamin D. And people typically go for walks early in the morning or late in the evening, and typically like to avoid the sun because it may be too hot and oppressive, or they may have skin allergies, or a very typical Indian mindset, we don't want to get tanned and look dark. So dietary sources, 100% only non-vegetarian. So if you're a vegetarian, you don't get any vitamin D. Even if non-vegetarian, it's primarily fish and egg yolks. And even in India, even when people tell us they are non-vegetarians, they probably consume only once or twice a week chicken or fish or any other kind of meat. So the amount of fish intake or sources of vitamin D become less. And then food fortification of vitamin D, things like milk or atta or any other things, that food fortification hasn't become a major public health program. I think there are only patchy supplies of milk that is fortified. And the other thing is, of course, people using sunscreens and their present lifestyle of sitting indoors all day. People who work in IT companies or corporate offices with a lot of glass, they hardly get any sun exposure, which may explain one of the reasons why young people seem to be having a lot of vitamin D deficiency. Next slide, please. So the UVB related deficiencies could be advancing age, dark skin. The darker the skin, less we absorb. This may be a natural protective mechanism that was given to us. Otherwise, people living in tropical countries would become vitamin D toxic. So the darker the skin, the less we absorb. And the usage of sunscreen, which I've already mentioned, we don't really have too much of seasonal variation, unlike Western countries where seriously 12 hours of the day, many people do not have, during the day, they may not have sunlight at all, or the sun goes down very early. And of course, latitudes. Like I mentioned, people who live in the tropics versus the temperate climates. But then there are other serious conditions like malabsorption disorders, people who have undergone bariatric surgeries, certain medications, and especially like seizure medications and other medications that interfere with absorption of, cause fat malabsorption, liver and kidney disease. Obesity is a very big risk factor for vitamin D deficiency, and smoking. Next slide, please. So many of these induce enzymes that increase the metabolism, or there are other issues, which is one of the reasons why many of the medical conditions are associated with deficiency. The signs and symptoms of vitamin D deficiency. So typically, till the level falls to a critical point, usually when they become frankly deficient, probably below 10 nanograms per mil, we really do not see significant symptoms. Patients may have vague muscle aches and pains or some cramps, and what we can look for are like a change in a waddling gait because of proximal myopathy. They may actually have some bone tenderness, especially anterior tibial tenderness, rib cage tenderness, and presenting with fractures. And the symptoms can be like in general, aches and pains and muscle weakness. When I was a medical student, we had a condition. I think Professor Arul Raj can attest to this. When women came into the clinic with vague aches and pains, they were called, KKK, which was, Kai, Kal, Korachal. Kai is hand and Kal is leg and Korachal is pain. And just probably, this is nothing, and prescribed some, pain medication or and then sent off. When we now know, probably all these women were suffering from something like vitamin D deficiency or a fibromyalgia accelerated by vitamin D deficiency. And then many people have a lot of difficulty with, squatting, walking up the stairs, and then more frequent falls, which may predispose them to fractures. So one of the things Dr. Bilizikian did the study has shown that 50% of people who have osteoporosis or have a osteomalacic component, meaning they are vitamin D deficient. So when we assess a patient for osteoporosis and we make a diagnosis of osteoporosis or osteopenia, I think it is really the onus is on us to make sure that we assess vitamin D, replace the vitamin D first before we consider putting them on a bisphosphonate or a anti-osteoporosis medication for two reasons. Reason number one is, like I said, a big component of their low BM, bone mass is from the vitamin D deficiency. So that will cause an improvement. The second thing is, on top of the osteomalacia, if we go and give a bisphosphonate, they will actually have more bone pains. And people have been known to actually become, frankly, hypocalcemic especially when given an IV bisphosphonate like zoledronic acid. So it's really important for us to make sure that we have normalized the vitamin D before we initiate treatment for osteoporosis. Next slide, please. So we go on to the, comorbid conditions, conditions that have been known to be associated with vitamin D deficiency. I'll try to run through them quickly so we can have a little bit more time maybe at the end for some questions. Next slide, please. So first one is hypertension, and there are many mechanisms underlying how vitamin D deficiency could lead to the development of hypertension. And we, just want to put it out there that hypertension is so much more common than any of the conditions that we usually talk about. It's an unsung serious problem, cardiovascular risk factor. So vitamin D deficiency can result in hypertension through either the RAS, the renin-angiotensin-aldosterone pathway, or effect on vascular endothelium, or role of PTH itself. We know that people who have hyperparathyroidism can have hypertension just directly from effect of parathyroid hormone and also sympathetic hyperactivity. Next slide, please. Next slide, please. Okay, so this is a bit of a complicated pathway, but just to say that vitamin D has been known to be, suppressor of the renin gene expression. So naturally, that will lead to, decreased renin production. So the converse, what will happen if somebody is vitamin D deficient, their renin levels will go up. A steady increase of plasma renin concentration across a declining concentration of calcidol or calcitriol. Calcidol is, D2 and D3 is calcitriol. And another study reported significantly higher angiotensin II levels in patients with vitamin D insufficiency and deficiency as compared to those with sufficient vitamin D levels. Next slide, please. So multiple mechanisms. Next slide. This is on vascular endothelium. So vitamin D has demonstrated in animal models and in human models its effect on vascular endothelium. There are vasoprotective effects. It has vasoprotective effects like reducing the effect of advanced glycation end products. And as you can see, this could have a significant impact on people with diabetes, increasing release and activity of nitric oxide, which is always important from an oxidative stress point of view, reduces pro-inflammatory and pro-atherosclerotic cytokines. Again, very, very important effect. So you can imagine when somebody has vitamin D deficiency, these protective or beneficial effects are probably attenuated. Next slide. So we all know this is one of the best ways, the flow-mediated dilatation for studying endothelial dysfunction. So in a study of endothelial dysfunction by flow-mediated dilatation in asymptomatic vitamin D deficient subjects, shown a significant improvement after vitamin D replacement. So again, there are things that we can tangibly see outside when vitamin D deficiency happens and when replacement happens, as in symptoms like muscle strength or grip strength or fall prevention or patients, cramps going away or local muscle tenderness. Then there are things that are happening behind the scene. We have no way of knowing except when it ends in a hard endpoint like increased risk of hypertension or diabetes or end result of cardiovascular disease. Next slide, please. So the role of parathormone is very, very important. And we all know that when patients become deficient in vitamin D, there is a reflux mechanism. Obviously, vitamin D is necessary for calcium absorption. So when calcium goes down, phosphorus tries to balance that, and then parathyroid hormone comes out trying to balance the whole thing. And the property of parathormone are many. It has effects on calcium, effect on phosphorus, effect on excretion of these substances, and its effect on bone and the sympathetic system. So it has a pro-stimulatory effect. Vitamin D, the secondary hyperpara that happens from vitamin D deficiency, a pro-stimulatory effect on vascular smooth muscle via changes in the calcium flux that can happen, release of endothelin and release of renin. We already talked about renin release before. Next slide, please. So all of this will lead to increased peripheral vascular resistance that will lead to hypertension. Next slide. So multiple studies, whether it is from a large enhanced data of a large number of patients in the US, where these are all correlations that have shown that between blood pressure and vitamin D levels. And this has been, again, an observation that has been further corroborated by other studies. In another big study, which is a meta-analysis, involving something like 78,000 subjects, what they found was an inverse relationship between vitamin D and hypertension. Next slide, please. So, as I've shown in this hypertension section, multiple mechanisms and multiple studies that correlate vitamin D deficiency and causation of hypertension, and a normal vitamin D and its protective effect on the vascular endothelium and other functions. The question that needs to be answered, I think, in a big way is, by supplementing vitamin D, how much are we going to improve the hypertension? I mean, common sense tells us that at least we should optimize the vitamin D, give the people the benefit of the doubt. Next slide, please, which is vitamin D and diabetes. Next slide. Multiple mechanisms again. Pathophysiology of insulin resistance and type 2 diabetes and vitamin D deficiency. Very interesting. Some of these are putative mechanisms. It's a contributor towards insulin resistance and development of type 2 diabetes via two mechanisms: a direct effect of decreasing binding to vitamin D receptor, and indirect effect is of course the its effect on calcium flux. And then you can also see effect on lipoprotein lipase, which will lead to an increase in triglycerides. All of these are components of insulin resistance and the metabolic syndrome. Next slide. And then there are molecular mechanisms of vitamin D deficiency and development of insulin resistance. So we know there is impairment of pancreatic beta cell function, impaired insulin signaling and sensitivity, impaired hepatic lipogenesis and gluconeogenesis, and then impaired cellular mechanisms, bioenergetics. So cellular mechanisms, impaired mitochondrial function. So at multiple levels, it is having an impact. And all of this, of course, will have downstream effects, which ultimately could be a RAS pathway activation, or it could be conversion, the increase in parathormone itself, or it could be the calcium flux that we talked about. So again, all of these then become complementary in causing the insulin resistance and type 2 diabetes. Next slide. So in a country like ours, where we are having, I would like to call a pandemic behind a pandemic, which is diabetes and cardiovascular disease, twin pandemics behind a regular pandemic, we need to look at every possible avenue to every possible opportunity to decrease the risk of the amount of type 2 diabetes and hypertension and heart disease in the country. And also for those who already have it, how can we optimize their outcomes and decrease mortality and end organ damage? So there is a high magnitude of overlap between vitamin D deficiency and type 2 diabetes or hypertension. Should we be routinely screening people for early diagnosis and effective management? Obviously, this is a cross-sectional, observational, but pan-India study across 29 sites enrolling 1,500 patients with type 2 diabetes and hypertension. And what they found was prevalence of vitamin D deficiency was higher in newly diagnosed cases compared to already diagnosed cases in all three cohorts. Is it because once they are already diagnosed, their physicians are supplementing them with vitamin D, they are under closer care, or is this something that is more a trigger? So out of the 1,257 patients, the 84.8% received vitamin D supplementation. And so we will talk next about, how do we supplement and what is the frequency and how do we monitor. Next slide, please. So oral supplementation of vitamin D, by the way, there are so many ways to supplement vitamin D. We used to do injections when, many years ago. Still, I think it happens randomly here and there. But we can give, oral supplementation in the form of granules, in the form of tablets, in the form of liquid. There are so many ways to do this. We can, talk about how much to give and what is ideal for whom. So oral vitamin D supplementation of 60,000 units. In India and some of the countries, it's 60,000. In the West, in the US and other places, it's 50,000. For 6 to 8 weeks, significantly improves vascular function and reduces oxidative stress in type 2 diabetes. Because we also have to show that it's like a proof of concept that by supplementing, we are changing some of the things that we talked about. So improving vascular function and in decreasing oxidative stress. Next slide, please. So again, just like I showed you for hypertension, for diabetes also plenty of studies linking vitamin D deficiency and in people with diabetes. In a big retrospective study of 4,500 plus patients, nearly 86% of the patients were either insufficient or deficient. Again, in another prospective study from India of over 100 patients, 87% of the patients were vitamin D deficient or insufficient. I'm not surprised by this because, baseline itself, we have so much of vitamin D deficiency. And since we have shown the link between the extraskeletal effects of vitamin D and what happens in these conditions and the mechanisms by which they could be correlated, it makes, again, like I said, common sense to optimize the level of vitamin D. Next slide, please. So, since COVID came on the scene now about 7 months ago, the role of immunity and role in infections has taken center stage. There are people who look at vitamin D as a magic pill that they must be taking to prevent COVID, to treat COVID. They keep doing all of these things. So let me show you a little bit about immunity, but not much time on COVID today. Next slide, please. So recent evidence points towards increased role of vitamin D in improving immunity, as I just mentioned, thereby preventing microbial infections and death. Next slide. So as you can see, there are multiple mechanisms, whether it is enhancing cell-mediated immunity or a physical barrier to infections. What they have shown is that it increases the space between cells so that it makes it difficult for the pathogens to enter the cells, for modulating adaptive immunity. So multiple mechanisms have been postulated. Next slide. I know I'm oversimplifying the whole immunity part. Next slide. So like I said, maintains the space between the cells, forming a barrier. Next slide. So increases the production of natural antimicrobial molecules, cathelicidin, and reduction of cytokine storm. I think that's another, very big thing that we have learned in the past few months. What is a cytokine storm? Next slide. And then, of course, suppresses inflammation and autoimmunity by reducing the production of TNF alpha. So important inflammatory chemicals. Next slide. So the modulation of immunity plays an important role in reducing susceptibility to microbial infections. Plenty of data on, respiratory tract infections, UTIs, even tuberculosis. Vitamin D may also help improve response to vaccines and vaccine-mediated immunity. I think this is exceptionally critical because the vaccines are right around the corner, and we should maximize their response to us. I think we need more data on this, but optimizing vitamin D across the board in terms of sun exposure, in terms of taking the right kind of food, making sure that people don't use sunscreens, making sure they don't stay indoors all the time, and for those who have documented vitamin D deficiency, optimizing their levels and getting into people's history. There are so many people who are, their food history, malabsorption history, and other comorbidities, and making sure that we optimize their vitamin D level. Next slide. So continuing this is consistent association, low serum concentration of vitamin D, susceptibility to acute respiratory infections, which we have talked about, several immune pathways. So the net effect is boosting microbial defense mechanism, mucosal defenses, and suppressing excessive inflammation. And then a reduction of antimicrobial peptides in response to both viral and bacterial stimuli, suggesting a potential protective mechanism against respiratory pathogens. And this whole respiratory pathogens are not going away anywhere. Even if we get a vaccine and get over COVID, we will have the seasonal flu, we will have other respiratory infections going on every year, and who knows what will come up next. So I think it's really important that we pay attention to respiratory infections. When I used to travel to Asia and saw people always wearing a mask, I thought it was because of allergies or smog. Now I see the wisdom in what they were doing. So I think it's really important that we get into a mask culture. Next slide. So seasonal influenza, which I just talked about, we must, all of us physicians, we must ask our patients to take the flu vaccine, and people who are older have to get the higher quantity vaccination, higher potency vaccinations, and pneumonia, higher 25 hydroxy concentrations, leading to reductions in cytokine storm. So one thing that has been established is, I think people who have very low vitamin D levels seem to have poorer outcome when they have COVID, but does not necessarily mean that everyone should be taking very high doses. We have had several instances of vitamin D toxicity, people taking it in a unsupervised, uncontrolled setting. That is something, unfortunately, due to WhatsApp and Google and other things. So we must encourage our patients to do all of these things in a supervised setting. So next slide, please. Okay, so this is just basically a summary of what I have said so far about cellular and adaptive immunity and how this happens, and finally direct microbial toxicity. Next slide. How vitamin D actually works in these things. Must be started or increased several months before winter, not only from an infection point of view. I talked about seasonal affective disorders, and the optimum level, anything more than 30 is optimum. If we can keep it somewhere around 40 to 50, it'll be great, because the natural tendency of vitamin D is, if there is no exposure or the supplementation goes down, the level will just keep going down and return back to where it was. So it is one of those conditions. It's not a one-off, one-time treatment unless major lifestyle changes have been made, or that there was something that malabsorption or something that was happening that got completely cured. Otherwise, this is something, it's an ongoing, baseline supplementation that has to happen. And definitely anything more than 100 is toxic. That is why we do not want to hit anything more than 60 or 70. I would aim to keep it 50 or below. To maintain the levels after the first month, the dose can be decreased. So vitamin D 10,000 per month has been indicated to be effective. That is absolutely 10,000 per day. That's absolutely the upper maximum. Beyond that, it is toxic. So I think up to 4,000 is very safely done. And many of our Indian patients, the obese patients, pregnant women, need around 2,000 to 4,000, and not the 400 to 600. So one of the important things to keep in mind is, between Institute of Medicine and the International Osteoporosis Federation and other professional societies, there has long been a debate about what is optimal and how much should we supplement our patients. And of course, there is variation based upon ethnicity and skin color and obesity and other things that they may be interfering with the absorption. So we'll have to play it by what our patient needs. Next slide. So treating vitamin D deficiency. Once vitamin D deficiency has been established, and again, the numbers here are anything 30 and above is optimal. The Institute of Medicine says anything above 20, they are okay with that. So between 10 and 12 and 30, you can call it as insufficient, and anything below 10 is clearly deficient. There are some minor differences in numbers. Some would call 12, up to 12 as insufficient, and anything below 12 as deficient. And or if you want to remember just the numbers, 10 and 30, below 10 is deficient, and 10 to 30 is insufficient, and 30 and above is sufficient, and up to an optimum great would be if you can keep it around 50 or so. So this is what we need to do. So if you have established vitamin D deficiency or insufficiency with symptoms, the best way to treat is to give the patient 60,000 units once a week for 6 to 8 weeks. Follow that up with once a month for 6 months. So 6 weeks, 6 months, it's easy for them to remember. In this interim time, if they have changed if they are going out in the sun, and when they go out in the sun, they have to expose at least 20 to 30% of their body, sun exposed areas, and they have to go out for about 20 minutes or so, and somewhere between ideally 10 a.m. to 3 p.m. So this is when you can get the sunlight. Or our government has suddenly decided to do food fortification and fortifies all the milk and everything, then things will start improving. You can then, like I said, monthly, we can always give 60,000 units, which will amount to 2,000 units per day. You can also give it as 2,000 units per day in people who are deficient, the ones, like I said, who you want to give, once a month. On a daily basis, I think, ideally, though the societies recommend 400 to 600 units, that looks like that may not be sufficient for a lot of people. So somewhere between 600 to up to 2,000, depending upon if they tell us what their diet and their symptoms and their daily lifestyle, exposure to sun, use of sunscreen, all of those things we need to tell them to get off that. But I think they need to be on a higher dose, especially people who are obese. Next slide, please. And all of this, all the time, with the concomitant, calcium supplementation, or reinforcing adequate calcium intake in their diet. So considering that the typical vitamin D level in most Indian studies was found to be very, very low, between 4 and 15, the upper end shows recommended intake may be appropriate. So 600 to 1,000 IU daily for low risk people. And people who are less than 50 years of age. But if they are high risk, people who are already have osteoporosis, or people who are frail, much older, or have any of these other conditions that I just, long list of conditions I mentioned, 800 to 2,000 IU for high risk and in older adults. In older adults, we don't want to give this once a month a big dose, or sometimes people were getting once a year big doses. We don't want to do that because that seems to increase their risk of falls. Okay, so we definitely don't want to give more than 4,000, but up to 10,000 has been considered safe, and beyond that is considered unsafe, could lead to toxicity. Next slide, please. So if you cannot measure vitamin D level for any reason, at the expense or anything else, the best thing is at least is to measure a calcium and an albumin level, because we want to make sure that we are not dealing with that patient with hyperparathyroidism, in whom you go and give vitamin D and calcium, and we could push them into a hypercalcemic crisis. So at least that much safety we have before we start the treatment. So common oversight in management is to stop treatment once sufficient levels are obtained, which is why I said we should maintain for 6 weeks followed by 6 months. And after that, if things have not changed, you could either measure the level and keep replacing them, or you can continue the once a month treatment, which will only tantamount to 2,000 units per day. So need to continue maintenance therapy, especially in high risk group, to ensure the optimum levels of vitamin D. So optimization is really the key, most important. We don't want higher than optimum levels. So Maintenance therapy once a month is recommended. Most of the professional societies have recommended that. Next slide. We're almost come to the end. Next slide, please. Next slide. So this is a new area, the creating vitamin D supplementation using nanotechnology. So this is a lovely cartoon that shows, in terms of, just to put it out there, how small is a nanoparticle. So you can look at what is a full stop that we use with a pen is 1 millimeter. And a nanometer is smaller and smaller and smaller than that, as you can see. So these are nanoparticles. Next slide. So next slide, please. So this is a very small particle. So nanoparticles and nanotechnology, I'm no expert on this. I myself just learned by studying this. So nanoparticles are colloidal particles that they range in size from very small, 10 to 1,000 nanometers in diameter. Okay, so this whole this novel drug delivery system, that's what NDDS stands for. It's a first time in India and comprises of nanoparticles, very small particles, and then very stable in the GI conditions. I think that is really important, and ready to absorb, so that at a given dose it will produce a higher level. Next slide. So they created the vitamin D in a nanoparticle, encapsulated in a lipid nanoparticle with a hydrophilic surface. So that is what makes it survive in the harsh GI environment, and how it is able to release the drug. Next slide, please. So this is like I said, the novel technology. There is no need for disintegration or dissolution. Absorption is not dependent on lipids. So we know that when we used to give the vitamin D by granules, we had to ask people to take it with milk or buttermilk, not dependent on bile salts for the micelle formation. Promotes absorption of vitamin D across the entire small intestine, and through and then there are multiple pathways that it is using, and not a single pathway. Next slide, please. So these are the multiple pathways, making the bioavailability more, the stable nanoparticles. They work through multiple pathways. Next slide. So the traditional ones only use the passive diffusion. This uses multiple pathways. Quickly, there are 3 studies. Next slide. 3 studies that have used. One is, this is an animal study, which looks at this novel drug delivery and what it does in terms of intestinal absorption. Next slide. And then this one, in normalizing vitamin D levels in people with vitamin D deficiency. And I really want to mention one important thing, looking at quality of life questionnaire and seeing the improvement in physical and mental well-being. I think with vitamin D deficiency, we really underestimate its impact on mental health and quality of life. And we tend to look at it very clinically in terms of, fractures or pseudo fractures or proximal myopathy or cramps or things like that. But it may actually be a more subtle, generalized sense of not well-being, ill-being, and vague aches and pains, worsening of their fibromyalgia, or just not feeling well, energy level is low. So that is really important to show an improvement in that. Next slide. So this is the last one, to be better in achieving higher levels. So this was in adolescence, and we, as president of ISBMR, just want to say that, bone health begins in utero. So optimizing pregnant women's calcium and vitamin D level is of paramount importance. And then throughout childhood, because osteoporosis is actually a pediatric problem with a geriatric manifestation. This doesn't suddenly happen one day. So unless our peak bone mass is attained when we are, adolescents and young adults, that's like money in the bank. That's what we keep taking out later in our life. And if we have missed that, if that window has closed, then we are only keeping putting band-aids to prevent fractures. So it's really important that we optimize the levels throughout a person's life. Next slide, please. I've come to the last slide. So diet, increased melanin content of skin, inadequate sun exposure, and lack of food fortification contribute to the high vitamin D deficiency. And of course, pollution, stripping away the ozone layer and so many other things, using sunscreens. Vitamin D deficiency has been implicated in development of hypertension, type 2 diabetes, susceptibility to infections. And recent guidelines recommend maintaining vitamin D levels will be, I think, showing improvement, not just in their skeletal signs and symptoms or improvement in bone mass, but actually in a whole lot of other conditions, particularly quality of life. And the new technology of the novel drug delivery system ready to absorb has just added more to our capacity to improve vitamin D levels in our patients. Thank you so much.
Thank you very much. Madam, that was a fantastic presentation. And you also gave a fantastic overview of this vitamin D. Vitamin D creates a lot of confusion in our minds, and I have a lot of questions bubbling on my mobile, on the chat box, etc. Sir, are you there? Dr. Suri? Okay, by the time Dr. Suri logs in, Madam, this vitamin D creates a lot of confusion, There are various preparations available, there are capsules available, there are tablets available, there are granules available, there are aqua preparation available, there are nanotechnologies available, there are syrups available, there are injections available. A lot of my orthopedic colleagues have a habit of giving those injections regularly. What do you think? What kind of preparations to choose? Is there any particular preference of one particular preparation over the other? You spoke about nanotechnology and advantages. You think we all should switch over from the conventional drugs to the nanotechnology? Your views on it?
So I have stopped using granules. So I use only tablets or liquid. Nanotechnology. So only two. We don't use injections also anymore. We have reserved injection to a patient, let us say, some genuine issue with absorption. Is not able to absorb the oral, replacement, and in spite of it, continue to have problems, or extreme osteomalacia where they are even unable to sit. We have tried to. It's for very rare niche use of injection, but pretty much it's only a tablet or using the liquid. And between the two, seeing the benefits of the higher levels and better GI absorption, it just makes sense to use the liquid. And patients also seem to like it's a single dose, little bottles of it, and they just have to open it and drink.
Yes,
so it's
very
not
convenient. Yes.
So if it is in multiple doses, again it becomes a problem. Whereas the single dose things makes it, the compliance is better.
Interesting. Madam, now in continuation with the same thing, see, there are a lot of generics available. There are so many preparation patients taking on their own. There are so many MBA products and similar products available. Patient may be on multiple therapies. And do you think, do you come across situations where their vitamin D levels cross 100, where the vitamin D levels become 150 and so, and if they really get so? What kind of presentations these patients have and what kind of complications they can get because of hypervitaminosis?
So previously, before COVID, I used to see, once in a while, a vitamin D toxicity. Either patient was given a prescription for 60,000 once a week. By mistake, they took it every day, or they didn't stop it after 6 weeks. They kept taking it for a long time, situations like that. Then they ended up with vitamin D toxicity. But after COVID, I've seen so many because they heard that vitamin D, they hear that vitamin D is good for COVID. It will prevent it. It will improve it. They won't die from it. They hear lots of from the University of WhatsApp. So then they started taking a lot of it, and I've seen a lot in the past few months, and the symptoms are nausea, lack of appetite, constipation, just generalized malaise and fatigue. These are the main symptoms. And then when you measure the vitamin D level and calcium level, you will get the diagnosis. The unfortunate thing is vitamin D is stored in the fat. So you can't make it go away overnight. So they'll just have to hang in there and slowly, and it'll go away. If their calcium level is high, of course, then we can, think about how to get that down, hydration, steroids, other mechanisms, other things we can do.
Thank you. Thank you. Suri sir, there is a very interesting question. This insomnia, is it disease by itself or it is a symptom or a part of a wider disease spectrum? How do you look at insomnia? Sir, you will have to unmute yourself.
Do it again, it is muted. Yeah. So insomnia is both a symptom and a disease, because you can see insomnia as a part of disorders. It is as a part of psychiatric disorders like depression, anxiety. Then a person with the anxiety will present with sleep onset insomnia, a person with sleep maintenance insomnia, and maybe early morning awakening. You can as a symptom, but what we see that most of the patients who have insomnia to begin with, then they develop what we call as psychophysiological insomnia, where because of insomnia they become somehow aware of the fact of the sleep, that they are not sleeping well, and then they start thinking about the ill effects of poor sleep, and they become too conscious about the sleep that they start worrying about it, and then they develop a state where they start dreading going to their bedroom, because the moment it's a time to sleep, they will start thinking that it's now a time to sleep, whether I'll get the sleep or not. If I don't get the sleep, what will happen tomorrow? So this is what we call as a psychophysiological insomnia. So it becomes as a perpetuating factor. So what started as a symptom of depression may actually become a primary or superimposed psychophysiological insomnia. So if you are treating what we call it, now we call it comorbid insomnia. So a person who has underlying depression and psychophysiological insomnia, what we call overlap or comorbid insomnia. So here you have to treat both with antidepressants and also with cognitive behavioral therapy to take care of the psychophysiological component, which was added later on.
Sir, in continuation with the same thing, how are the stages of sleep important clinically? How do we understand about the REM and the non-REM sleep, and will it have any clinical significance?
See, it's a very important question, and also difficult, because still we do not know truly what is the function of sleep. We know what is the function of sleep is through the experiments of sleep deprivation, where you have done acute deprivation experiments. A person is not allowed to sleep for 40, 22 hours or even much more than that, and you see the changes. Or you see patients with chronic sleep deprivation, where they are sleeping for 7 hours, 6 hours, 5 hours. Through that, from those effects, we say indirectly what is the function of sleep. Now, your question is that if you look into the normal sleep architecture, we entered into sleep from wakeful state through non-REM sleep, where you go from stage 1 to stage 2 and then stage 3, which is the deepest stage. And then we have the REM sleep. Now, as we grow older, deep sleep becomes much lesser. So from that, you tend to deduce that the deeper sleep is much more useful when you are physically very active. So younger people, they will go to play, they will have a lot of physical activity. As you grow older, your level of physical activity goes down unless you make it happen, actively going to the park and walking for at least half an hour or 1 hour every day. So the most common sleep period is stage 2 sleep, which is stage 1 and 2, which is a light sleep. Stage 3 sleep is actually it is a highly efficient sleep. When you have sleep deprivation, and after that you will get much more of stage 3 sleep, so which is a rebound sleep. Similarly, if you are REM deprived, if you have normal sleep, then you have REM rebound. So the stages, exactly what is the function of stage restitution? What is the importance of REM sleep? We say it is more for mental restitution, mood stabilization, memory consolidation. So from this, you try to differentiate. But now we know that there is a lot of overlap. The memory. If you see memory, there are different types of memories. Spatial memories, the skill memories. So something which is done in REM sleep, something the other types of memories are done in not REM sleep. So those people who are totally REM deprived, they won't have total amnesia or complete loss of memory. So sleep is a very, very complex area, and what exactly happens in deep sleep, what exactly happens in REM sleep, we only know the tip of the iceberg. We only know the major things, and a lot goes deep into it. And as more and more research comes, we know more and more about it. But so far, only in the nutshell, I can say that when we sleep, we should have adequate amount of deep sleep. We should have adequate amount of REM sleep, and the sleep architecture should be good, and there should be minimum arousals during the sleep. So if that is there, then sleep quantity and sleep quality both are important.
Yes, look at the irony. I mean, something which is our daily need and we understand so little about it. Madam, there is a question. This vitamin D thing, you test vitamin D and everybody's vitamin D is low. I am 90 kg and I thought I'm like, well, mota aur bacha and have no problem. When I got my vitamin D tested, it was 8. I really doubted the report and I got it tested from another lab and that also came low. Now, in your opinion, what are the common reasons of vitamin D deficiency in so-called healthy people? And that too, when we live in a country like India where there is abundant sunlight available. What are the reasons behind? And do you think in that scenario, vitamin D testing should be part of your routine investigation now? Madam.
So, by the way, I tested my level and it was 6.
So at least mine also better than yours. Cool.
Yeah. So I tried to put something. I was on a plane and I tried to put something for my luggage up there, and suddenly I found all my muscles went into spasm. So as soon as I came back to Chennai, I tested my level. It was 6. So the reasons are, like I said again, vegetarians, zero source of vitamin D. The sun exposure has come down dramatically because our jobs are all indoors, and even those who are able to go out, you can see they cover themselves up to prevent either sunburn or tanning of the skin, or they may have sun allergies, headaches when they go in the sun. So for so many reasons, they don't go in the sun, and our work timings do not allow us to be out between 10 and 3 o'clock. And then the darker the skin, the less you absorb. So even when you go to rural areas and measure the vitamin D level of men working out in the hot sun, and because over a period of time the skin has become even darker from continued sun exposure and the melanin content, their absorption goes down. And then, like I said, pollution, so many things. So, but obesity is another risk factor. We do not know, because it's chicken or the egg. Did they become overweight because they didn't go out? And therefore, they are a couch potato and they have vitamin D deficiency, or because they have vitamin D deficiency, they have no muscle strength and no energy and don't go out. So a little bit of chicken or the egg. But the truth is that people who are overweight and obese have lower vitamin D levels. So these are all the multiple reasons. And then there are genetic reasons. There may be polymorphism. So this is the reason why in a country like India, we are seeing so much. But I want to just add a small, word of caution. What is normal for us? As in, if 90% of the population is vitamin D deficient, what is really a normal level for us is again a little bit of a question mark. Should we go by Western standards, or should we go with exclusively Indian standards? So the best thing to do is, in people who have symptoms, in people who have comorbidities, in people, for example, obesity, or people who have undergone bariatric surgery, malabsorption, in those, I think we should definitely test before giving them higher doses for supplementation. For all others, I think we should give general guidelines on minimum amount of vitamin D intake and calcium to be taken, if you see that their diet and lifestyle is not going to provide that.
Great, thank you. We seem to have a lot of questions and time is overshooting, but still, Suri sir, Dr. Ashok Bakshi has a nice question. Do you think 4 hours of sleep in 65 years old male patient is good enough? I think the question is incomplete. I would probably make a question a little easier for you. Do you think a 4 hour sleep in patient who's 65 years and asymptomatic is good enough? Sir, you have to unmute yourself again.
See, there is a huge variation in the amount of sleep we need. Because first of all, we have to understand, why do we sleep? We sleep because we are physically tired and we are mentally tired. And for that process, you need a given amount of sleep. So the need of sleep in terms of number of hours in a particular individual would also depend on the amount of physical activity they do and amount of mental activity they do. So as you grow older, many people think that most of these people are not doing physical activity, and also they are probably retired from the active professional life and they are not mentally very active. So their sleep need should come down. But that is not true. Even a person who is 80 years old or 90 years old would require same 8 hours of sleep as the person at the age of 20 or 30 years. The only thing is that their ability to consolidate their sleep probably may be low at an older age because the homeostatic drive to sleep goes down. There are many things, your melatonin secretion is less, your sunlight exposure is less. There are so many factors out there which cause what we call as graying of sleep. Like you have graying of hair, you have graying of.
And they may end up taking sleep.
But the need of sleep does. Pardon me?
Perfect. What you're saying is right. And sir, they may also take fragmented sleep. They may sleep for a couple of hours at night. They may sleep for a couple of hours during daytime as well. And probably cumulative 6 to 8 hours of sleep they may probably end up receiving. Do you think that would serve the purpose?
Not only that, because their sleep quality goes down. To compensate for that, their duration may in fact increase, and that is why they start napping in the afternoon. And
sir,
but in no way their sleep is less than others.
Sir, there is one more question by Dr. Snehal Shah. That is also a very interesting question. She wants to know which is a good drug for good 6 hours duration sleep for people who are elderly, say 80 and above. Which drug would you consider the safest if they have no other comorbidity? Suri sir?
See, prescribing sleeping pills. Yeah, can you hear me?
Yeah.
Can you hear me? Yeah. It's very important for the physicians who are prescribing these sleeping pills to understand their half-life, their onset and duration. Because when we are giving sleeping pill, we want it to act only during the sleep period. We don't want a spillover effect, and we don't want that the effect should be over before the sleep is over. So for that purpose, I think we have these Z drugs, those. So if you see those, the zolpidem and this thing, and the one drug, the azathioprine, is the one which has 6 hours. So if you are using zolpidem, which has a short period, 2 hours, then you should use, I think, a long-acting preparation. Which is slow release or a long-acting preparation where that the duration of action can be extended from 2 hours to 6 hours. Otherwise, you may have to actually take in the middle of night, if this patient wake up. On the other hand, I would not recommend the use of conventional benzodiazepines, because most of them will have a half-life of 18 hours, 24 hours. In some cases, maybe even.
Great. That was my next question. That was my next question, sir. And you already answered that. The question was, there was a very interesting question about conventional alprazolam versus the newer like zolpidem. But I think you very well covered it, that benzodiazepine should be avoided, especially in elderly people, and your focus should be on newer drugs like zolpidem. Thank you. Madam, there is one question for you. And again, Dr. Snehal Shah is asking this question, that you have given a course of 8 weeks of vitamin D as supplement, and you suppose if you repeat the levels are still not high. What would be your conclusion, or what would be your next plan of action? Would you give another course immediately after that? Would you wait, or would you investigate why this patient is not improving with this conventional therapy?
So I definitely would have some questions about why this has not come up even after 8 weeks of 60,000 units. Check on, did they take it, and do they have some malabsorption issues like that? Are they very obese? So, and then again, we don't want, when people repeat the measurement, the levels, they are expecting it to be somewhere in the 50, 60 or 40 range. We don't want all that. So I'm happy even if we have raised a person. See, the other thing to remember is when we see a level of 6 or a 10 or a 8, like in your case, the whole body vitamin D level is very, very low. So you have to put in a lot to bring the level up in the pot. So you may take some more time for this patient to get into to an optimum level. So what I would do is, while I'm checking the vitamin D level, also check a calcium level, and if I find that to be still low, then I have no problems repeating another course and bringing the level up. There are no challenges. We just
should it be a routine practice, madam, to combine calcium when you're giving vitamin D?
I think always calcium should be given, because the importance of calcium supplementation, we know. If the patient, if it is a younger patient and their dietary calcium intake is good, then just vitamin D supplementation is good. Postmenopausal women also need calcium.
Thank you very much, madam. Thank you, sir. Thank you, madam. We have still few questions, but I think for want of time, we'll not be able to take it. I thank all the delegates who have given their time, who have been with us, and you are encouraging us with your presence, because your presence makes us do this program, and it's only your presence that makes this program successful. I thank Dr. Suri and Madam Shriram for giving your valuable time, your inputs, and your fantastic knowledge, and the way you've conveyed it to us. Probably I feel now I'm expert in sleep, and I feel now I'm expert in vitamin D disorders. Thank you, sir. Thank you, madam. I must thank the entire team, API, Dr. Arul Raj, Mangesh, my close friend, Dr. Tivaskar, Shashank, and the entire API team for doing this program so well. First, thank them for giving me this opportunity for playing a small role in this particular program. Of course, Team Abbott, your fantastic work, and your association for years together. I think it's like 6th or 7th year that we are doing this program, and during this unprecedented time, we are going to touch more than 1 lakh of doctors by the end of this series that we have. We have a very important series tomorrow. Tomorrow we are going to be discussing thyroid disorder, and I request all of you to please log in tomorrow. Please give us your presence. Please give us your encouragement, and we promise that we would give you a best program on thyroid. Thank you from my side, and now I request Jyotish to come and give a vote of thanks from corporate side. Over to you, Jyotish.
Thank you so much, Dr. Agam. Basically, I always say that Dr. Agam, so who can does the moderation job or so well rather than you. Thank you so much, sir. So I would like to start, from Dr. S. Arul Raj, the President of Associations of Physicians of India, for giving us this opportunity to collaborate with the Associations of Physicians of India for API-DAS initiative. Today is the 23rd program where we have reached out to over near about 55,000 doctors as of now. Thanks to entire delegates and the entire API team for this. I would also like to thank the close brother, Dr. Mangesh Tiwaskar, and astute Secretary General of Associations of Physicians of India, and Dr. Shashank Joshi, the mentor of mine and in person, for giving us the opportunity. I would also like to thank today's chief guest, Dr. Ajay Khera, who is basically country representative of Engender Health, and before that actually he was a former deputy commissioner in Ministry of Health and Family Welfare. Would like to also to thank today's anchor, Dr. L. Srinivas Murthy, for steering the ship so well. Thank you so much, Dr. Murthy. Special thanks to both the faculty today, Dr. J.C. Suri, sir, it was really an honor to have you today, and Dr. Usha Srinam, who had joined from US today, from Chicago, right in the morning, for today's program. Thank you so much, Dr. Usha. We will be always in touch with you for such kind of initiatives, and we look forward for your valuable time as well as valuable advice for the fellow physicians to improvise patient outcome. Thanks, Dr. Shuri. Thanks, Dr. Usha Sriram. And brother, he told me that actually, that I am his elder brother last time. So Dr. Agam Bora, thank you so much. Yeah, so do join us, for tomorrow's program, which is on the thyroid, as Dr. Agam said. With this, I would also like to thank the entire team from Abbott, with Mr. Rajasekhar Akkaraju, who is the Senior Director and Regional Head for Quality for all of our Abbott products that we provide in the country. Mr. Ashok Saini, who is the Division Head, Ranjit, Sumit, the Marketing and the counterparts for the division, and also the team from Medical, Vinod, Kamesh, and my teammates, Somya, for this program. Special thanks to Swati for leading the efforts from the back end and for the entire program. Thank you so much. Please do tune in tomorrow.
Thanks, Jyotish. Have fun. See you tomorrow. Bye-bye.
See you tomorrow. Yeah. API.